It's when we went, we were all at Ames, right? For 2 days we were all.
Yeah, you were there. Yes, I
अच्छा
remember.
MSPGI से किया भाई, उसके बाद MCH गया है।
ओह सर, गुड इवनिंग।
Good evening.
आप दिख नहीं रहे ना सर, आप अदृश्य हो।
आपने जब्त कर दिया, आप जो पीजीआई को जब्त कर दिए तो मुझे बोलना
नहीं
पड़ेगा।
नहीं, हम पीजीआई को जब कर ही नहीं सकता, कोई सब मिलके भी नहीं कर सकते सर।
और उसके बाद फैकल्टी बने थे पीजीआई में, देन हिज नेम्स नाउ।
Okay. Good evening, everyone. It's 7 o'clock. Let's start. Welcome to the 13th masterclass of Jaipur Surgical Tutorial. And Jaipur Surgical Tutorial, or JST as we call it now, is an online surgical education portal that we started at the Mahatma Gandhi Medical College and Hospital almost 3 years ago. And the regular activities of JST are managed by my colleague, Dr. Anand Nagar, who's an associate professor of HPB surgery and liver transplant at my institution. We conduct a weekly online educational activity every Saturday, 9 to 10 a.m. India time, where students present cases or operative surgery sessions, which are moderated by faculty. And last year, we started these master classes, which are held once in a month. It used to be last Thursday and Friday of the month, 7 to 9 p.m. both days. But very recently, IASG has started another academic activity along with the National Cancer Grid, which is on Friday evening, same time, 7 to 9. So we have now shifted the master classes to Wednesday and Thursday so that students can attend both the online activities. And this is the 13th master class, second part. Yesterday we did the first part. So today's session, I've requested our former fellow from SGPGI and now senior consultant at Pace Hospital in Hyderabad, Dr. Ravula Phani Krishna. He will be moderating the session. There will be 3 presentations. I think Dr. Kailash has not joined. He has just returned from US, I think today morning or yesterday evening. So he would be joining soon. But Phani, maybe we can request Ajay to start. So over to you. Please moderate.
Yeah, sure. For the first speech, first talk would be by Ajay. Ajay is, of course, we worked with him in Sanjay Gandhi, and now he's heading a very large and a very busy unit in Jaipur. I think he's going to talk about when to feed in CSTM, I mean, in Whipples, post Whipples, and it's one of the big contentious issues. There's a lot of controversy, a lot of anxiety from the surgeons and the patients, and there's a lot of data he has to go through. Ajay, thank you. You can take over from here, Ajay.
Thanks, Phani. Thanks. Can I request if I can share my slides? Can I be made a host so that I can share? Yeah. Are my slides visible? Is my slides?
Yes, please.
So, thanks, Phani. Phani, sorry, I could not attend the session yesterday because somehow there's actually a gradual posting of everybody. We all become teachers and grow in our family also. Now I am a grandfather now. So my elder brother's son had got a delivery yesterday. His daughter-in-law got delivered. So I was busy there yesterday, so I could not attend. And I agree with you that this is a very difficult topic to handle and very close to my heart. That is feeding after a pancreatico-duodenectomy. Yes, PD is very close. We have been doing a lot of Whipples in last so many years, and we have developed many techniques. But what is important for me to introduce is, so definitely PD is the treatment of choice. The main important thing related to feed is a delayed gastric emptying, which is still being documented to the level of 20 to 40%. But ERAS protocols have shown some promising results with PD also. So now how I will cover today's session is, first I will take up the traditional methods and the relevant anatomy. What is early recovery? What are the refeeding methods? How does the post-op complications affect the feeding? And how does a reconstruction affect the refeeding? And pending, how are we justified into it, which we can go for discussion subsequently. So traditionally, we know the patient has a rise tube in position. The feeding tubes are, as a ritual, they've been placed for years. Feeding started in feeding jejunostomy, say sometime when I remember was on day 4, day 5. First, the saline feed was being given as a clear water, a clear liquid for a day, and then half strength feed and in low volume over next 24 hours. Then started gradually increasing the FJ feed in next 24 hours. And once the patient is tolerating, that is the time that we feel that now we can give a large volume of feed by his feeding jejunostomy also. In case the feeding jejunostomy was not tolerated, the patient was again put on NPO, given IV support, or then if he's affordable, could be put on TPN. And if the patient was unable to tolerate in few more feeding jejunostomy trials in coming few days, then TPN was the option left. Some surgeons, we often know that since Dr. Kapoor is there and he was very fond of NJ tube and Riles tube both at the same time. This was also a very common area which was being used, both Riles tube and NJ. And NJ to feed was same as protocol as Riles tube, that started after few days, 4th day, 5th day, and then gradually increased it first half strength, 4th strength, not like a Riles tube feed which was started as a large volume feed on day 1. So maybe I can show this. This is the first article which I would like to refer, that the feeding jejunostomy in pancreatitic agent. Is it important? So most, I think in last discussions also we have seen, yes, this is an important thing, that feeding jejunostomy most of the surgeons will prefer to have. So why feeding jejunostomy is important is because definitely the patients who are undergoing PD can have major complications, and at that time they need a major nutritional support. So FJ can prevent from a long-term TPN. So FJ is one thing that is warranted and has been traditionally been put by most of the centers worldwide and even in the country. And yes, it is now, as I go on the discussion, we will have more contradictory remarks, more discussions and more things out of it now, out of the box that we have to think now to develop it. What has happened in last so many years is the changes were brought out after the eras in the various abdominal surgeries. Enhanced recovery protocols originally was for any bowel anastomosis, and the feeding was started in a day or after weeks, which was earlier. Now it has been started early. The preoperative fasting, which was used to be at least for overnight or a day prior to the surgery, has now cut down to 6 hours. Post-operative bed rest has restricted. They have started ambulation as early as possible. And these ERAS protocols have been studied mainly, which was started in colon and if you see for luminal surgeries. Initially, maybe for hernias and other things, they were being tried, but colon was the first data which has come for ERAS effective protocols. Many areas of debate in in early recovery protocols was an acute abdomen. Should we start? That was a lot of controversy, but now people have started in acute abdomen as well. As soon as the patient is settled, esophageal and gastric anastomosis, again there was a lot of controversy and discussions into it. But it was definitely tried for lap choles. Immediately day 1 we start feeding biliary surgeries, for perianal surgeries, for the small liver surgeries, hernia surgeries. And this was around till 2010, this was being developed worldwide. Now, why PD is different and it has not been worked up so much, even in ERAS protocol at so much time? Possibly, the thought process was, there's a post-op DG, which we are always delayed gastric emptying. We are worried. PJ leaks, which we are worrying. And post-PD, there can be major bleed complication, which again worries us. And complications difficult to tackle and long time to get normal after PD. It was unlike another luminal surgeries where you can re-explore, make a stoma. PD did not have those options. So a complication meant a long duration recovery time, difficult recovery, long duration of antibiotics, long duration of IV fluids. So possibly that is the reason that people have been suspicious of or doing early recovery protocols in this. Adding on to this more is that the patients for PD patients have been said that they have nutritional deficiencies. They have a poor general conditions. They have poor wound healing tendency, and they have been without enteral feeding for a long time. But I think these things will hold on for, I think, CA colon. Yes, they are also nutritional deficient patients. Poor general conditions, they bleed more. So they are all in poor conditions. They also have poor healing tendencies as with any other malignancies. So I think this is not, the nutrition does not hold only with the periampullary or head-of-pancreas, which requires PD, but for most of the other diseases as well, including small bowel, or even in tuberculosis of intestine, which we have a small bowel resection. So how the post-op nutrition after PD has been thought about? What are the modes? Definitely one mode which is controversial is still oral feeding, nasojejunal, as I have said, and feeding jejunostomy and TPN. These three have been the standard over these years. Feeding routes, what I have mentioned, that it has there's an article which shows that oral feeding, enteral nutrition, either by nasojejjunostomy, gastrojejjunostomy, or a jejunostomy tube, or a TPN. And in the last, you can see an early oral diet may be considered a preferred route of feeding strategy after PD. So enteral feeding is more important, and he says oral. So we will come to this discussion in the coming slides. Early oral feeding after PD. So I'm just going to the literature first before I go on to the discussions. That recent article 22, early oral feeding, you can see in the conclusion, currently available evidence shows that early oral feeding after PD is not associated with increased risk of delayed gastric emptying, does not exacerbate post-operative pancreatic fistula, and appear to reduce the length of stay. Now, I would like to just halt at this slide because though this publication is 22, if I go back to the literature, 2010 to 2014-16, that was the era when there have been a lot of discussion that enteral feeding increases the fistula rate. Enteral feeding, oral feeding increases the DG. Enteral feeding increases the complication rate. So after 2016, there have been a gradual decrease in the numbers of the complications, which have shown that enteral feeding does not increase the complication rate. And these are the recent data. So PD is associated with, it is not associated with DG, again with postoperative pancreatic fistula. Similar article, you can see the various articles which have used from Netherlands, Korea, Belgium, China, where they have started early oral feeding. And most of the articles have shown that it does not increase the complication rate. It can be well tolerated. Similarly, the DG, one of the articles in this which has shown that early DG, that DG may be increased. That was an old article. And in 2021, it is again shown one of the article, which was a small number of patients, again shows that there is an increased risk of fistula. But I think majority of other articles goes in favor that early oral feeding does not increase the complications. Operate the empirical therapy, what we can use TPN, but you need, this is a meta-analysis which has shown that post-operative pancreatic fistula is not increased. The support has to be required, and best route is the enteral. Early enteral versus oral nutrition after PD. This is a presently ongoing trial which has now on the midway, but its present day study, which was presented last, has shown that it has very, very positive results of early feeding, early oral feeding, not early feeding, early oral feeding following a pancreatico-duodenectomy. So after all this literature, we have thousands of literature which have been hovering around it, and most of them are now inclined towards early feeding. Do we agree that early feeding does not affect the PJ leak? Early feeding has no harmful effects on DG, and early feeding gives us no loss. If we agree to this concept after this literature, I think that is the time to proceed and think, should we start early feeding? So the first thing is the concept that does it increase complication? No. So presently, let us now come to the halt that at least the feeding does not increase the complication rate. That is the literature has shown us. Now, surgeries, we will be saying, say, now there are main three areas, that is classical PD or a pylorus preserving or a pylorus resecting, which we do. Now, it depends also on PJ technique and whether to do a FJ or not to do FJ. I'm not going to PJ technique because it has been vastly discussed in this in these sessions, but I'll be coming mainly to the classical PD, in which we know that the antrum is resected and the stomach is anastomosed to the jejunal loop, which after PJ and HJ comes into the gastrojejunostomy. This is a classical PPPD in which just wanted to show these two films just to show the size of the anastomosis, which will be coming in my coming presentations. The size of anastomosis in PPPD or pylorus resecting pancreatico-duodenectomy and a classical Whipples is different. The size of anastomosis is very important over here. This is one of my baseline line diagram which I have chosen, which shows a PD, a PJ, a HJ, and then subsequently a gastrojejunostomy. We know that the stoma size, I have written those 6 to 10 centimeters, but most of the time it will be something around say 15 or 20 centimeters of gastrojejunostomy, which is made following a PD between the stomach and the jejunal loop. What happens with this anastomosis normally? Let's come to it. What happens is the bile which is coming into the afferent limb has a wide area to go into the stomach and cause a lot of antral gastritis. This is the concept on which we work presently. So I'm just sharing my concept and the fact that which we feel as compared to the anastomosis, which rather than making a full wide anastomosis, if you make a slightly smaller size anastomosis, there's a preferential flow which goes into the afferent limb to efferent limb rather than going into the stomach. We know there is no pylorus, but decreasing the size of the stoma definitely decreases the reflux rate into it. Second thing, the peristalsis in the stomach. Again, coming to the same line diagram, the peristalsis in the stomach, that is from the fundus into the body and naturally goes towards the lesser curvature, towards the pylorus. It does not come onto the greater curvature side. Peristalsis in the afferent limb goes into the goes towards the stomach, and so there is a vice versa combination of the peristaltic action, which is we call as not an isoperistaltic, but it is a reverse peristaltic movement, and we have a wide anastomosis. So very high chances that this bile may reflux into it, and this peristalsis in the stomach may not help empty the stomach into the jejunal limb. This is the area where it should have emptied, and this is not helping us out in emptying the stomach. Rather, the peristalsis in the stomach, even if you see, if you do an anastomosis near the greater curvature site, it is still going towards the lesser curvature and toward the pyloric area. Even if the anastomosis is onto the greater curvature, which is a small luminal anastomosis, the peristalsis in the afferent limb will have decreased reflex, but it is still not emptying, helping us to empty the stomach. Now, if we see, I will not be talking much about PPD because PPPD is not the not we have been doing, and PPPD had shown some increase in the incidence of DG maybe, and then subsequent literature says that it does not. But I'll be restricting my discussion subsequently onto the pylorus resecting pancreatico-duodenectomy, where the stoma size, again, we say it is around 3 centimeter size stoma. We resect it just proximal to the pylorus, the stomach, and then do an anastomosis. So if we see for PRPD, how does it work is that the bile flow is, this stoma size is small, bile flow is in the peristaltic direction. There is less likely to have reflux, to have antral gastritis, which may be a contributory factor for irritating the stomach. The peristalsis in the stomach is in a normal line, which is a normal human being. Normally it goes towards the pylorus, so it would empty towards the pyloric side where we have an anastomosis. So it is more likely to have a better emptying as compared to the other anastomosis which we have discussed in classical Whipples pancreatico-duodenectomy. This anastomosis is still anti-peristaltic because the two peristalses are working in either in reverse direction. We may make it isoperistaltic, but we have found that isoperistaltic and anti-peristaltic anastomosis at this place does not make much difference in the gastric emptying, and both of them had same results in our hands. So now next is, after this anastomosis, is impact of an anticolic versus transmesocolic reconstruction. A recent article in which they have shown that transmesocolic reconstruction may be superior to anticolic reconstruction in minimizing the development of severity of DGE. So what do they mean by transmesocolic excision is, this is what they have shown in their line diagrams. This is a retrocolic anastomosis that they are doing a GJ proximal to the proximal when it is coming out from the mesentery. This is normally an anticolic gastrojejunostomy, and this is a transmesocolic gastrojejunostomy, and we normally prefer a transmesocolic gastrojejunostomy at our place. Now, what is the basis and why do we think so is the problematic technique, or it can be organ related. It is technique related or organ related. The problems, that is, one is PJ leak, which can be because of small PD or because of the soft pancreas. HJ leak because of an undilated duct or a difficult anastomosis. Both PJ and HJ leak and subsequently bleed, and these are actually, I suppose, to cause DG, decreased emptying. But I have a feel which I'm still not able to substantiate anywhere, because these are all what we have seen. But I still have a feel that following PD, there is always some inflammation in the pancreas, and there's some inflammation in the pancreas is in the area of the entire body and tail of the pancreas, which is left, and that affects the stomach motility because of the inflammation over there. So basically, the principle is GJ and stomach should be away from the site of complications in pancreatico-duodenectomy. Now, if we see that what he has done is retrocolic, the GJ still lies close to the complication site, that is the PJ and the HJ site. If we see that gastrojejunostomy, if it is made anticolic, the anticolic site, though it is away, but it can still retract. The stomach normally, when it contracts, it may retract the GJ site into the proximal area, where it can still come close to the site of PJ anastomosis, which may have inflammation, which may have leak, which may have decreased the gastric emptying in the remnant of the stomach. But if we see GJ, which is coming through the transmesocolic, we usually fix it to the mesocolic area, and this anastomosis is infracolic, which is away from the supracolic area, which has all the major anastomosis, that the PJ and HJ, and the complication of the PJ or the complication of the HJ and the inflammation in the pancreas all remain away from our GJ side. So possibly this empties better. That is our feeling. What we have done was presented by my colleague, Dr. Vinay Mehla, who had presented it in Japanese Surgical Society last year. And I'm exactly just copying his slide, which he had presented. This is a prospective evaluation of a protocol of a conventional oral feeding and to assess its effects on post-operative outcomes. What we have done is, this is the early oral feeding at that time in 26 patients, conventional oral feeding in 40 patients. And there was no FJ used in these patients, though FJ was placed in the conventional feeding method. And according to need, TPN was required. Here, we did not give TPN to any of these patients. Oral feeding was started 6 hours after the surgery, and conventional method, we started to do it early with a FJ or a nasojejunal feed. And day 2, we used to start SIPs, and then day 3, oral liquid diet. Here, we used to get a Ryle's tube removed a bit late, which we can remove early. But because of my fear that Ryle's tube reinsertion may cause problem, that is my philosophy. So I felt that we will remove it once the patient takes oral diet normally. And we used to give a complete diet at that time on day 3. And then the IV fluids were stopped by day 3, and day 4 onwards, the patient is on normal diet. Nasogastric tube, we used to remove on day 1, as I have already said. And most of the patients have got discharged by day 5, if no major complication was there. So results, we had a comparable data between the two groups, and we have found that days to start oral liquids, an early oral feeding group, 26 patients, was on day 0, soft diet on day 0, as compared to 3.8 days in the conventional feeding. The oral solid diet on day 3 versus day 7. Days for nasogastric removal was 1.3 to 3.9 days. And days for the first stool passage was earlier after we started early oral feeding as compared to conventional feeding. And the days to stop the intravenous fluid, definitely it was earlier if we start the early oral feeding. And the post-operative hospital stay, as all the data says, is shorter when you start an early oral feeding. So in this article, we have concluded that the early oral feeding after PD is feasible, it is safe, and reduces the hospitalization. And this is the slide I did not want to change, because my colleague Dr. Vinay had used this in JSS. So I still wanted to continue the same slide. And with that, I would like to conclude my session. But I would be happy if there's some discussion or any questions, because I know this is a thought-provoking idea with a lot of data support now onto early feeding. So maybe if any of the questions, Phani and Dr. Kapoor sir, maybe we can discuss on that.
Phani, please.
Yeah, Ajay, I think it was an excellent talk. I think one thing you established very clearly is that early and enteral feeding does no harm. I mean, it's definitely something which should be universally practiced. And I think the work you've done on PRPD, pylorus resecting pancreatico-duodenectomy, that shows, and the literature, the talk on early versus late oral feeding shows that you've done a lot of work on this. You've really put in a lot of work on this in your unit. In fact, this trans-mesocolic approach, it's not just you. It's been other people also thought about it. In fact, when we were in Asian Institute, I don't know if any of our Pradeep sir or anybody is there. We used to call it the infracolic approach. The infracolic approach. So there's anticolic, retrocolic, and the infracolic. To the left of the middle colic, bring the stomach out and keep it away from all the area of where all this, the inflammation is occurring. couple of things. One is, yeah, I mean, I think you just focused on that part alone. In terms of the DG techniques, all that, I thought you'll be covering those also, but you've just focused on this. But it's been a very focused talk. One thing is, not all patients of this thing are DG. One people, we assume sometimes that if the right vascular is high, we assume that it's DG. Sometimes they're actually due to technical adhesive obstructions beyond it, FJ kinks and all that. We've had a couple of experiences like that. And this thing of whether we should do an FJ at all or not do an FJ, I'd like to know your views on it, because after later on, after Whipples, trying to put an NJ is actually, it's a problem. It keeps calling back and all that. So have you completely given up doing FJs, or is it like, do you categorize them to high risk and low risk patients for DG and then do that?
I agree, Phani. What you're saying is very correct. Most of the centers do an FJ. We used to do an FJ long back, but fortunately, during my experience at SMS, we had a very vast experience of PD at that point in time, where we felt that putting an FJ used to help and some of the patients which had complications. Now, you have to be very sure that you don't have a PJ leak and you don't have a complication following a PD. If your complication rate is decreasing, then your FJ is not going to help you. That is for sure. FJ is going to help you when you have a complication. So first target is not on DGE. First target is on decreasing the complication rate. And I think I always tell to Dr. Kapoor that Blumgart should be given a Nobel Prize for his technique of doing a PJ anastomosis, after which worldwide the data has drastically changed on PJ leak. It is not only with us, but it is worldwide. So maybe, but we are very happy that we don't have a significant PJ leak, though now we recently had 1 or 2 patients which had a small leak and then subsequent complications. But most of the patients in last so many years, at least in our hands, maybe in experienced hands, I would say, they don't have a leak. So if the patient does not have a leak, doing a FJ may not be of much help. So if first target is achieving you may do a FJ till the time you achieve that you are PJ and HJ does not cause a complication. Once you have achieved that, with this we achieved somewhere around 2017, I feel 2017-18 was the time when I stopped FJ for time being, and I did around say 20 PJ without FJ, and I had a complication in one of the patients. I again restarted putting FJs at that point in time. Then after coming to Mahatma Gandhi in 2019, we initially used to put for 1 or 2 or 5 patients, and then subsequently we stopped it, because now that by that time I was confident that it will not happen. So now since then till date, we have not put an FJ. So maybe it is sometimes, yes, it may cause an harm, but it is so rare that I don't feel that it is much utilizable.
The transmesocolic GJ, which Ajay described, I am reminded of the time when we used to do a lot of surgery for peptic ulcer. They got me and GJ. And that time I remember, and I think for Carson, I don't know whether it is still mentioned, used to mention that you may do the GJ by bringing the jejunum up through the transmesocolic window. But once you have done the anastomosis, you need to pull the stomach down and fix it to that window so that finally the anastomosis lies in the inframesocolic compartment. So just an
I think Farquharson still mentions the same lines. Farquharson, I still recommend to my junior residents and colleagues, you should go through Farquharson, because Farquharson is conceptually a very strong book. It may not be technically. The Rob Smith is technically very good book, but Farquharson is conceptually very good book. So following Farquharson is better to develop baseline concepts. So I agree. And second thing, Phani, what you told is transmesocolic window. This is when we were passing out from SGPGI 2006. This was the first article which had come from the transmesocolic from Japan, and this we were going through when we were giving the exam. And I realized that this should be beneficial in coming days. And from then we started developing it, and I realized that definitely it works. Possibly you must have also seen that it works well.
Yes, yes. And in fact, ours was a DNB thesis, was an RCT. So we documented by doing a HIDA scan, a gastric emptying scan on day 7, and documented that in this infracolic group, it is actually, the emptying is better.
So Phani, to complete my presentation, I would like to add that now we are also, since this has not been accepted so many times, people don't agree to what we say. So Dr. Kapoor suggested to have a documentary evidence. So now we have started that scan now to document that the stomach is emptying into the jejunum in 100% of the patients. So to document that, now we are doing a scan, and we've already got the permission of that trial.
Isotope gastric emptying.
Isotope gastric emptying study now. So we'll be doing this in the coming years now.
Director, in the meantime, please make Dr. Kailash Kurdia as a co-host because he is the next presenter.
So
Dinesh or Himanshi.
what I think most important thing is this anastomosis being small in size, the peristalsis being in the normal direction, and the peristalsis of afferent limb not letting most of the things go. Though still bile will go into the stomach because we don't have a pylorus over there, but it works well. So that is my assumption, and maybe it is working because of that. I don't know, but there might be something else as well. And keeping it away from PJ and HJ. Now, recently in my maybe 2 days back or 3 days back, I was telling on my rounds that this PJ anastomosis always leaks in the anterior to the PJ. If it leaks posterior to the PJ, it will come out through the drain. But anterior to the PJ, it is always harmful. And that is the reason earlier, if you remember, we used to put one drain at HJ and one drain at PJ. Now we put one drain at PJ on the right side and one drain on the PJ from the left side. This left drain, I feel, is always more important because this will secrete something or the other. And this is the one which will have sometimes higher mileage. The right drain will not have any volume. Right drain may not have any mileage, but left drain will always have. But looking into the data retrospectively, my resident told, sir, what you are saying is both of them have an equal value. But I still feel every day we see the patient and the left drain is always having a relatively higher mileage as compared to right. So left side, PJ anastomosis leak is always onto the anterior side. And that is a possible reason which explains that the collection over here or an inflammation over here leads to a decreased emptying of the stomach. So this has to be taken care of much better. Right.
Ajay sir, what is the instance of delayed gastric emptying in your series?
After a long time, we have had one now. After many years.
Because one of the most important thing in Whipples surgery that we are doing around 60 Whipples a year. Most important limitations in Whipples surgery, I think, is delayed gastric emptying. It's still in best of the center is 25 to 30%. And if you're starting, and this type of DG generally occurs third, fourth day or fifth day when you start oral feedings. So when you start oral feeding day one, how you predict that it is not going to be a delayed gastric emptying or not going to be a PJ leak? Because finally outcome is not important to how early you start oral feeding. It is more important what is the rate of your delayed gastric emptying, which may not be any related to PJ leak or any complications of pancreatico-duodenectomy. Still it is 25 to 30%. Then how can you justify to start oral feed in day one and knowing that delayed gastric emptying can happen in 25%, means 1 in 5 patients of pancreatico-duodenectomy?
Yes, Utpal, that is definitely a controversial issue. That is definitely a point of discussion. That is definitely a very much vibrant discussion between me and Phani so many times, between Pari and me so many times, and with other colleagues. But I still feel either our patients are different, I don't know. But we have not seen a DG. When Dr. Kapoor joined, you can ask him. It was very difficult for him to accept this fact that there is no DG. But now everybody is doing, and there's hardly any DG. So this is a factual data. This is a factual data which was actually compared between the two groups, age matched groups and everything. And after that, you can see that there's hardly any patient which is having a DG. So I feel that this is my feeling. Either we have different patients or there's something different. This is the details of the trick which I have told you, that what we do in our anastomosis is a mesocolic anastomosis. We do only a pre-pyloric resection always. This is the classical anastomosis we do. We take care of PJ leak is hardly there and nowadays. So I don't know, but DG doesn't happen.
So Dr. Ajay, data you are showing that in 26 patients who have started in early internal feeding, this data may be biased. Maybe some good patients with hard pancreas, with the large duct, which has a lesser chance of pancreatic leak. So you have started in this subset of patient early oral feeding, and you have get good results. And that conventional feeding in 40 patients, maybe that bad type of pancreas, like soft pancreas, undilated, that there are high chances of PJ leak. So you have started in that patient conventional. Until unless you do randomized control trial, you cannot say conclusively that this is actually, you cannot make conclusion based on this data.
Let me no, I'm not telling you to make a conclusion based on the data, but let me come to this fact, this feeling, this status. What you are saying is that these two groups are different. No, these two groups were same. Problem is, this is what my colleagues used to do when I joined. They were not ready they were not convinced for doing a early oral feeding. And so this is their data. This is what I was doing. Subsequently, we all agreed. And subsequently, now everybody is doing. Now, 100% of our patients undergo, we don't do any patient to start feeding on a later time. We start feeding on 100% patients on day one, rather on day 0 now. So it is irrespective of the type. Yes, definitely PJ leak is very less, which I agree. And maybe in coming years, if we have some complications with PG or some collection or DG, yes, we may have to change, but till now, and this is only the part, this is only the tip of the iceberg which I am showing, because the data which I have was enormous in numbers before coming to Mahatma Gandhi. And actually that was the one which had made me to feel on this direction. So that, this is just the tip that you are seeing. This is the slides which was used for presenting in the Japanese Surgical Society conference. This is only a small spectrum which we were showing, comparing the two groups. But if you see the entire group, if you see, if I show you my the data which I was writing was on more than 650 patients in 7 years, which out of which almost 200 were having early feeding. That was a huge data which I feel. Which I was writing, but by that time, multiple other publications, and then subsequently that data I was not having that complete data when I was working at SMS and in the other private centers. It was only after coming to MGH that we started having a collaborated data now. So maybe that is a limitation of it. Because of the small numbers, yes, you may agree to it. You may say that this looks like a small number, but this is only the tip of the iceberg that you are seeing.
Before I ask Professor T.D. Yadav to give his opinion, this thing, Utpal, we are looking at two separate issues here. One is early oral feeding, then other is incidence of DG. There is clear-cut data, level 1 evidence, quality evidence in literature, so that showing that early oral feeding does not have any harm. Even if you don't feed orally, DG is going to occur because there's saliva, gastric secretions, pancreatic biliary secretions, 4-5 liters, it's handling. The early oral feeding is not a contentious issue. I mean, whether this Ajay's technique delays gastric emptying, what are the best techniques, what is the difference, that you can debate. But I think even especially in PD, and in fact most after gastrectomy, after bariatric and acute pancreatitis, there is clear-cut literature even in PD that early enteral feeding is not the cause of PJ leak or delayed gastric emptying. Maybe we are a bit hesitant that okay, we feed early, there's delayed emptying starting on third day or something, the stomach is going to get hugely distended. But that I don't think anywhere it's been shown that early enteral feeding is actually the etiology behind delayed gastric emptying. Professor Yadav, you've been quiet. I'm sure you must, I mean, over the years, you must have a huge experience of this and your own thought process about this. Could you share your thoughts?
No, but thank you, Phani. But the question is, we are discussing it with Dr. Ajay earlier also. I think 1 or 2 points are important. One is that when he showed the picture of total end of the stomach being taken into, I think that practice was, I don't think anybody would do, because all the modifications and most commonly used modification, child modification, which uses part of the towards the greater curvature to maintain the same type of flow and closing the upper part of the stomach, that usually even after gastrectomy, even after all those things. The thing is that Ajay has shown his data, quite amazing data, that the pancreatic leak is so less, and those things are very important. We know that nowadays you can put a tube. Recently, I was doing one pancreatico-duodenectomy, so I put because there was a most probably acute pancreatitis, and I was not very happy, patient little bit of heavy. So we put a anastomotic tube. And if this patient is private ward, so I thought if there is a problem, TPN can be given. So somebody is seeing it, and if then only he can believe it. And our as a department, our numbers are huge. You see, we are crossing about 75 per year. But the question, not me alone, all the 3-4 people who are working in the department. But we are we are realizing that PJ leak is not in our hand. Most of whatever good anastomosis you do, sometimes a little bit of early pancreatic leak might convert into established pancreatic fistula, might heal. These are the some issues, but as you said, the transmesoquilic part, which is has been described, that is one small anastomosis. And orally, day one, I have not yet started. And we try to put a rice tube, but don't try to aspirate. This is also true that food is a good agent to start peristalsis. Yeah, any oral diet. And in a small bowel anastomosis, our agent used to do start orally same day, because we pushed all these things, colonic anastomosis, all those. But here in pancreas anastomosis, there are some factors that Dr. Utpal was trying to highlight, that if pancreas is duct is dilated, if pancreas is firm, and you can do a good anastomosis on the table, you look, it seems you are very sure that it is not going to leak. Ajay usually is a consequence of PJ leak, usually doesn't leak if you are very careful in doing that. But in a soft pancreas where you are small duct and lots of fat around, all the factors which are responsible for the PJ leak are there. So I think we can take this as a one of the inspiring thing by Ajay, and some modification can be done, but I am still not sure whether a day one we can start early and day 5 can be discharged. So it depends on the surgeon to surgeon. This would be my thought process. The
Thank you.
Ajay,
the
I think
patient.
we need to,
Yes, sir. Yes,
yeah,
sir. So,
we need
Just
to move
two
on.
things I would like to add to what Dr. TD was said. One thing, actually, there's a lot of data now. One thing is that, however happy sometimes we were with the PJ anastomosis, however good the pancreas was, it would leak. And sometimes the pancreas was so bad in the initial days and still it will not leak. So I don't know what the reason was at that point in time. Second thing is, now while I was going through the data on PJ leak with feeding, there's a lot of data now which says that this feeding decreases the leak rate. So I don't know. I did not put that into the slides now because that will add one more controversy to it. It says that once you have a started oral feeding, so there is a jejunal stimulation. That jejunal stimulation increases the peristalsis in the jejunum, which has a siphoning action on the pancreatic juice. To rather than going into the leak site, it goes into the jejunal loop. So there were some articles. So I don't want to put all those controversies, but yes, enteral feeding can be started, and maybe if somebody can try, it will add to our experience as well.
Let's move on. Only thing is, I have suggested, Ajay, that we should document this by doing these isotope gastric emptying studies where we can show that early oral feeding stimulates the stomach and may be decreasing the risk of DG. Phani, please ask Kailash to.
yeah. The next speaker is Dr. Kailash Kurdia from All India Institute of Medical Sciences. Kailash, I think while DG is such a oral feeding, it's such a controversial topic. One of the areas where we have very good quality evidence, and which has definitely made a big difference in management of pancreatic cancer is how you define borderline pancreatic cancers and the role of neoadjuvant therapy, which has led to improved outcomes. So I'd like request Dr. Kailash Kurdia to take over.
So while Kailash is speaking, I need to inform all the students that Kailash did a very beautiful review on what are the various Kailash, please share your presentation.
Yes, sir, I am sharing.
Various definitions of borderline resectable pancreatic cancer. And after he finishes, I'll project a slide that how you can get that review from us.
Is my slide visible?
No.
Dinesh.
दोबारा स्टॉप करके फिर से शेयर करो. नहीं, प्रेजेंटेशन खोल लिया है?
हाँ सर, यस सर।
ओके, फिर से करो कई बार।
Are you sharing the whole screen or the PowerPoint?
आई एम शेयरिंग अ पीपीटी।
नहीं, पीपीटी खोल के डेस्कटॉप पे रख लीजिए, देन यू लॉग इन, तब शेयर करिए, सॉरी।
ओके ओके।
पीपीटी खोल के उसको मिनिमाइज करके तब शेयर करिए, तब आता है। और मैक में थोड़ी प्रॉब्लम कभी कभी लेता है बिकॉज ऑफ द सिक्योरिटी इश्यूज।
It says that you have started screen sharing, but it says the double click. फिर से चला। So students, please send me a mail, vkkapoor.india@gmail.com. Write BRPC in the subject of the mail, and I will be happy to send you the soft copy of the review which Kailash has done with me on BRPC.
It is showing unable to import JST, BRPC, and NACT. Trying restarting new PowerPoint or opening the file in PowerPoint to troubleshoot.
या तो फिर लॉग आउट करके दोबारा लॉग इन करो फिर।
एक बार वो प्रेफरेंसेज में जाके देख लीजिए, अलाउ करने का भी कई बार होता है कि अलाउ द दिस थिंग, है ना, आपके वो जो सेटिंग में
ओके
आ गया।
दिस इज नॉट।
ये तो मेरा है, ये तो मेरा है।
ओके ओके,
I'll stop. I think Kailash has logged out, so I'll just show this to the students. So students, please note this number. You can send a WhatsApp message to Dr. Anand Nagar to join Jaipur Surgical Tutorial, and then you will get information about all the online sessions, including the master classes. All these videos have been uploaded by the IT team of Avinash Tak in Dwarika Clinic, Ahmedabad. They offer all the technical support.
Avinash, are you there? Are you here?
नहीं, उसकी टीम होगी अविनाश की जो IT.
I mean, one option is if it does open next time, he can mail it to. I mean, if it's not a very heavy presentation, he can mail it to Avinash, and they can play it. Sir.
Let Kailash log in. Ashwini is there. Ashwini wants to make any comment on Ajay's presentation.
Good evening, sir.
Good evening. Anything? What is your feeding practice?
Sir, even though our numbers are not great, we do about 10 to 15 Whipples per year. And we don't do any feeding gymnostomy. We keep a NJ tube, and we don't even keep any nasogastric tube. And we start on day 1 feeding.
But that is NJ feeding.
NJ feeding, sir. No oral. NJ feeding. Oral day 3, day 4.
Okay. The conventional.
Day 3, day. Yes,
conventional
sir.
protocol. Yeah.
Yes, sir. Yes, sir.
Okay.
Yes.
Hello.
Yes, Kailash.
Sir, it is showing host disabled participant screen sharing.
एक minute. Yes, you are not a co-host. Dwarika Clinic, please make Dr. Kailash co-host again.
Yes, sir.
Funny, now we have tubes which can be inserted into the stomach, which have a double lumen and can be used for both gastric decompression and
Kailash, ab karo.
Yeah,
How
yeah.
you are?
No, Fracas tube. Yeah, we have it like
Precast tube
a
that can
trilumen.
be used for
Yeah,
it. So that can be used for as
that
a
can be
separate
used.
tube
Yes,
itself.
yes.
महंगा है.
I agree, sir. It is costly.
हाँ. So the problem is this.
Yes, sir. But rather than putting two tubes, that is an option.
नहीं, वो ठीक है, जैसे बात करो, हम लोग तो ये सब चीज देखना पड़ता है.
नहीं, I also agree. हमारे यहाँ भी थोड़ा सा कई बार कॉस्ट का वो आ जाता है, इशू आ जाता है. But FJ, if you, my personal feeling is FJ is better if you want to put rather than two tubes. But Kapoor sir is always happy putting an nasogenital tube. And I still remember during SGPG times we used to have a controversy whether FJ versus two tubes. And I remember Dr. Rajneesh once telling that after their rounds on Saturday they used to have a major round, and on Friday PD was done. And on the
Kailash, share karo.
round it was asked, where is the FJ? So that resident had actually forgotten to take the FJ out from the abdomen, and he has put a FJ tube into the jejunal loop and forgot to take it out. So some things or the other. And once there was a contact, Sujay told that there were two tubes and they got knotted into the stomach. So some of these complications can happen, though they are rare. And I think oral feeding has no much complications. If only thing is it is difficult for us to digest.
We've used the Freca tube quite a bit. I mean, yeah, it's good. You know, this thing. I mean,
For a gastrointestinal, what do you use, Phani? Do you use a tube?
I mean, so it's been highly selective, man. That's like a long discussion. We select, I think 80% of the Whipples, we don't do a feeding jejunostomy. A small group of high-risk patients like soft pancreas.
Maybe if Kailash is having problem,
Yeah.
maybe we can have Utpal's presentation so that.
Yes, I think so.
Utpal, please, आप stream करो,
Okay.
Kailash sort out कर लेगा.
Or you can mail it to Avinash team and they can play it. That's the best
I will
thing.
talk to Kailash. I will talk to him.
The screen is visible, sir?
Yes, please. Go to the full screen mode.
Yes.
Yeah.
Good evening, respected seniors and colleagues. At the outset, I would like to thank Dr. Kapoor sir for giving me the opportunity. I will be discussing what we can achieve with the vascular resection in modern day pancreatic cancer cells. So pancreatic cancer is as a whole is a systemic disease, as demonstrated by many clinical and non-clinical literatures, suggesting 96% of the resectable pancreatic cancer cells have detectable tumor cells in the blood circulations. So not uncommonly, most common site of recurrence is distant metastasis, most commonly in liver and lungs. So what is the basis of local control? Why local control is so important? Why we are emphasizing the venous resections, arterial resections so much, knowing that pancreatic cancer is a systemic disease? So we use a CT scan to define non-metastatic pancreatic cancer into resectable, borderline resectable, and locally advanced tumor, depending upon the involvement and extent of involvement of superior mesenteric vein and superior mesenteric artery. So vascular resection is not a newer concept, and it was demonstrated by Fortners long ago, 1977, by publishing a series of regional pancreatectomy where the superior mesenteric vein or superior mesenteric artery was resected, but at that time there was very high morbidity and mortality, and long-term survival was very rare. The most common cause of this low long-term survival was the R1 resections margin. So in the last decades, most important advancement in the pancreatic cancer surgery was the improvement in neoadjuvant chemotherapy regimen, specifically for FOLFIRINOX or gemcitabine or the paclitaxel regimen. This neoadjuvant chemotherapy regimen not only help in systemic control and local control, but also determines the biological behavior of it. Now, we give neoadjuvant chemotherapy in almost all cases of borderline resectable pancreatic tumor. Maybe it is involving venous or artery. So in these borderline resectable tumor, we have high CA99 level. And after giving this neoadjuvant, if the CA99 level reduced to normal, then this type of tumor are very much have higher survival rate when venous or artery resection is done. And many literature clearly shows that T4 means involvement of artery and vein is not an independent parameters to predict advanced tumor or survival. So the involvement of superior mesenteric vein and artery is just a technical problem because of anatomical proximity and not a biological, it shows the biological aggressive nature of the disease. Second important thing is the CT scan criteria is only used for the diagnosis unless we use neoadjuvant chemotherapy. Once we use neoadjuvant chemotherapy, CT scan is not very much useful in diagnosis of this locally advanced or borderline resectable tumor because it fails to differentiate between the fibrosis and the viable tumor. So as long as possible in the era of this fall for inox or gemcitabine treatment, local control is very much important in suitable selected biologically improved biologically selected pancreatic cancer patients. So coming to the case, it is a 52-year male. This patient has uncinate tumor involving superior mesenteric vein. Superior mesenteric artery was free, involving D1, D2, presented with gastric outlet obstruction with high CA99 of more than 700. So it was anatomically borderline resectable tumor. Biologically, it is aggressive tumor with high CA99 value, but patient general condition was good. So he was first underwent gastroenterostomy, then received 6 cycles of neoadjuvant chemotherapy in form of FOLFIRINOX. They re-evaluated with CT scans, but do not show progression of the disease, although it was superior mesenteric vein was still showing encasement, but it has drastically reductions of the CA99 level of 1886 international per milliliter. So it was known as I was taken up for the surgery. This was the tumor. This was the portal vein, this superior mesenteric vein, and this is the partially divested superior mesenteric artery. And this is the triangle which is formed between the celiac axis, superior mesenteric artery, and mesenterico-portal axis. Here, splenic vein need to be resected, and all the tissues here been cleared of the fibrofatty tissues. When triangle operation is completed here. Then clamp is applied 1 to 2 centimeter proximal or distal to uninvolved portions of the tumors, and resection tumor is taken out. And end-to-end anastomosis between portal vein and superior mesenteric vein done with 6-0-proline in continuous fashion. So final histopathology came as marked fibrosis with no residual tumor, and post-operative course was uneven. So I want to stress that in this type of tumor a decade ago was unresected. Now with neoadjuvant chemotherapy, now it can be completely resected with no residual tumor. So this is what we have achieved in modern day practice with the use of neoadjuvant chemotherapy and venous resections. So coming into venous resections, international study group of pancreatic surgery classified venous resection into 4 types. First is suture. Second, we use the patch if the involvement is more than 30% and there is chance of lumen stenosis. Then third is segmental resections and end-to-end anastomosis, and fourth is use of the graft. Most commonly used venous resection is type 1 and 3, and most of the complications occur in type 4 venous resections. Where we use the graft. This graft may be PTFE, and most of the complications occur with this PTFE graft. There is high risk of thrombosis and bleeding, infectious complications, pseudoaneurysm, increased risk of pancreatic, post-operative pancreatic fistula. Most commonly, autologous graft we use the internal jugular vein, saphenous vein, or renal vein, and now it is most common. It is dogmatic. We use peritoneal patch, which can be used as a patch or can be used as a whole graft. And this is important because we have shown in 33 patients that is patency rate is over 96%, and it is done from the same incision site. There is no morbidity. There is less chance of infections in comparison to that of synthetic graft, and any size of length can be obtained by using this peritoneal patch graft. So this is important additions in the grafting of the portal vein where it is required. Then the steps of venous resections are: first is adequate proximal and distal control of the vein, then mesopancreas excisions. This is most important part because ultimate goal of this entire venous resection or artery resection is R0 resections. So this is most important part to clear superior mesenteric artery margin clearly. So I will discuss later on what is LV1 resections, what is LV2, what is LV3, and what should be done. Then the standard PD step unless the specimens will be attached to the patients only at the tumor and vein site, then clamping out in the uninvolved portion of the vein, then resection and anastomosis. These steps can be made easy by use of these 4 maneuvers. First is cattle breast maneuver, second artery first approach, third is SGL clearance, and fourth is triangle operations. I will discuss one by one. In cattle breast maneuver, we mobilize entire right colon, including the hepatic flexure and small bowel mesentery, and then this all things is kept in the left upper quadrant of the abdomen. And this causes mesenteric mobilizations, and Del Caro showed that in 44 patients that up to 7 centimeter range of the gap can be approximated without any use of synthetic or any graft. So this is important thing. So if you're planning for venous resection, and that it should be started with the cattle breast maneuver, because it almost eliminates the need of any interposition graft. Second important aspect is artery first approach, because we first get control of superior mesenteric artery, which is most important thing. Generally, we in this type of locally advanced or borderline resected patients who receive neoadjuvant chemotherapy, first thing is to know whether after getting control of superior mesenteric artery, whether the tumor is involving the artery or not. So first thing, after getting control of the artery, we took tissues along the artery and sent for the frozen section to confirm whether there is a viable tumor or not. If the tumor is not present, then we move then for further proceed with the divestment and other triangle operations. So most commonly we do artery first method is the right posterior method, or median uncinate and left posterior method. These 3 are most commonly used. Other uncommon methods are inferior infracolic, which is also called transmesocolic method, then inferior supracolic, which is called anterior method, but it requires neck transections. And sometimes when common hepatic artery is involved, then this superior method is used as an artery first approach. Our preference is the right posterior, where we use wide cochrations. This is left renal vein, and superior mesenteric artery right just proximal to the left renal vein. I will show you in the video. And other is this is median uncinate process, which we use frequently when tumor is involving the uncinate process. So this video is showing the right posterior approach, wide cochrations. This is the IVC. Then first thing is to loop the left renal vein. Then superior mesenteric artery is just proximal to the or cranial to the chest. There's this left renal vein, which is covered with dense fibrous and fatty tissues and lots of neurogenic tissues, which requires careful dissections. And then superior mesenteric artery is looped just approx cranial to the left adrenal vein. So this is the superior mesenteric artery. Another approach is median uncinate process approach, where after the cochrations we first mobilize portal vein, then superior mesenteric vein after dividing inferior pancreatico-duodenal artery from the beginnings. So these 2 approaches are used frequently by us in cases of the venous resections. Next important thing is mesopancreas excisions. This is, as I already stated, this is the most important aspect, because in order to get the clear SMA margin. And so after the transaction of mobilization of DJ and transaction of proximal jejunum and getting back jejunum into the supracolic portions, we first see this portal vein. And portal vein, then after mobilizations, the first jejunal vein is visible, and this is the 2 inferior pancreatico-duodenal vein, which is training into the first jejunal vein. Thereafter, the superior mesenteric artery is visible, and this is the first jejunal artery, and then followed by inferior pancreatico-duodenal artery. And sometimes this in both arteries form a common trunk of the inferior pancreatico-duodenal artery. So there is 3 types of dissections. One is LV1 dissections, where we mainly concentrate along the portal vein, like in this figure, because you can be clear that in LV1 dissection we do not see superior mesenteric artery. We are mainly concerned with the superior mesenteric vein, and superior mesenteric vein branches are first taken out, then inferior pancreatico-duodenal veins are taken care of, and we do not see entirely SMA. Here, this LV1 approach is not recommended for the cancer surgery, because we do not remove the SMA margins, and most of the mesopancreas remains with the tumor. So this is not standard of care for the cancer surgeries. Second is LV2 resections, where we, after mobilizing the superior mesenteric vein, it is looped and it's taken upward and outward in order to expose the superior mesenteric artery in a groove proximal to the first jejunal vein. So first, the plane of resection in the LV2 resection is like that. First, we ligate first jejunal artery, then inferior pancreatico-duodenal artery, sometimes at the base of the inferior pancreatico-duodenal artery. And this is the preferred approach for the tumors which is not involving superior mesenteric vein, or not, it is a simply resectable pancreatic tumor. It is not the borderline resectable or locally advanced tumor. So this LV2 resection should be done in every cases of the periampullary tumor. And third is LV3, which is equivalent to periarterial divestment, where the adventitial layer, there are many perineural tissues which is being removed during the dissections, and it's called LV3 dissections, and it is usually done in cases of borderline resectable tumor who have received neoadjuvant chemotherapy. So chemotherapy. So in standard practice should be level 2 LV2 resections, and in cases of the borderline resectable who have received neoadjuvant chemotherapy, the level of resection should be LV3. That is periarterial divestment. So this can easily be done by the laparoscopic method, and we use frequently. This is the first way we taken care of the inferior pancreatico-duodenal vein. First jejunal vein can be sacrificed, but usually we do not sacrifice the first jejunal vein. It is sufficient to ligate this inferior pancreatico-duodenal vein. Then small branches from the SMV, which is going into the uncinate process, need to be divided. Then we took the portal vein outward and to the left side, which exposes the first jejunal artery, then inferior pancreatico-duodenal artery. This is the line of dissections, and then this completes the LV2 dissections. I will show you in the this video. This is uncinate dissections. First, we try to remove adhesions from the portal vein and try to loop it. So assistants retract the portal veins outside. Then after retractions, both sides of retraction, first thing visible is first jejunal vein, and this is the inferior pancreatico-duodenal vein draining into first jejunal vein. We first ligate this inferior pancreatico-duodenal vein, and then first thing that after remaining resections comes is first jejunal artery, which need to be divided. This is the first jejunal artery. And thereafter, after ligating and remove, this is the first jejunal artery. Next thing visible is inferior pancreatico-duodenal artery, which is clearly visible here. This is the inferior pancreatico-duodenal artery, and it is part of the superior mesenteric artery, which is visible in entire process of the dissections. So in this way, we do LV2 dissections, level 2 dissections. Dissection in order to get clearly superior mesenteric artery margins. And this is last things, that is superior pancreatico-duodenal vein is being done. That is removal of the mesopancreas from the SMA attachments. And this is entire mesopancreas is being removed from the SMA. And so this is the level 2 dissection, and this would be the norm in cases of the pancreatic tumor. And sometimes you can go directly into the base of inferior pancreatico-duodenal artery. This inferior pancreatico, first jejunal and inferior pancreatico-duodenal artery branches has been ligated and going into directly into the base of inferior pancreatico-duodenal artery arising from the superior mesenteric artery. Next important thing in the venous resection is the complete hepatoduodenal ligament mobilizations. This is should be complete explanation of the portal vein, bile duct, and hepatic artery. This is important in order to get the first is lymph node, second proximal portion of the portal vein, and third most important thing is to get acquainted with any vascular anomaly, like if arise right hepatic artery arising from the superior mesenteric artery. By doing SGL dissections and explanations, so we can be careful what anomalies are there, and we can get complete control of the proximal part of the portal vein. Then next step in doing this is strangle operations. The strangle operation was first defined by the Thilo Eckert and Buchler Heidelberg group, and the strangle is formed between the superior mesenteric artery, this is celiac artery, and mesenterico-portal axis. And being because the basis of doing this strangle operation is this perineal growth. Pancreatic tumors are peculiar to have perineal growth, and specifically these are the locally advanced or borderline resectable tumor, and who has received neoadjuvant chemotherapy or chemoradiation therapy. So there are lots of tissues there in the strangles which need to be removed in order to get R0 resection, which is ultimate goal of any pancreatic resections. So, these are to be removed completely. This is the protocol which is being followed in the Heidelberg groups by the Thilo Eckert and Buchler group. First, they give neoadjuvant chemotherapy, and they do not use the neoadjuvant radiotherapy because we're thinking that radiotherapy damages artery, and risk of artery and vein and risk of venous thrombosis are more when they add radiation therapy. So mostly they give neoadjuvant chemotherapy, FOLFIRINOX based or gemcitabine or paclitaxel based, and if it is stable disease on CT scans, because CT scan do not show whether it is a progression or complete resolution, then surgical exploration is done. Then after artery first approach, further section is sent from the tissues from the critical sites. If there is no tumor, then triangle operation is being made. Then this is the review article by the same group, which is 330 patients. It is retrospective studies. Triangle surgery was matched with the other cohort where triangle operation was not done, and it was shown that more lymph nodes were harvested in triangle operation. There was rate of R1 margin was dropped. There was comparative post-operative mortality and complication was comparable with that standard Whipples. The duration of operation of blood loss was significantly higher in cases of triangle operations, but long-term survival and data is still to be out. So they are doing a randomized control trial doing triangle operations versus no standard methods, but results have yet to come. So this is an important part of the process of the research. So following this principles, all the principles I have decided, I have already mentioned. So this is large neuroendocrine tumor, which is involving superior mesenteric vein and draping superior mesenteric artery. And following these principles, what we have, I have described first control of the proximal and distal part of the portal vein, portal and supramesenteric vein, then supramesenteric artery is completely divested, triangle operation is done, then is normal steps of the pancreatico-duodenectomy, specimen is hanging on the junctions, then clamp is applied 1 to 2 centimeter proximal and distal to the uninvolved portion of the portal vein, then specimen is being removed, and last step is end-to-end anastomosis using 6-hydroproline. In this case, spleen vein was preserved. So sometimes small there is accidental detections of the portal vein in the small periampullary tumors also. So it is converted. This patient is converted to open, and here splenic vein and this is inferior mesenteric vein and splenic vein. And we have splenic vein can be preserved, and end-to-end anastomosis of portal vein can be done. So even if you get accidental or unplanned resection, if you can achieve R0 resections, then the outcome is not different from those which are planned resections. Then what about splenic vein, which need to be lagged? Because splenic vein is the main source of left-sided portal venous drainage, specifically from the stomach and spleen. So it may lead to left-sided portal hypertension, or cause bleeding from the PJ side as well as the gastric varices bleeding. So it is important to know what is the status of inferior mesenteric vein. If inferior mesenteric vein is intact and is draining into splenic vein, then it need not to be reconstructed, because it can be drained by the inferior mesenteric vein into colonic vein and it goes into the portal vein. But if inferior mesenteric vein also need to be resected, then splenic vein reimplantations is required. Either it can be done into the same side of the portal vein proximal to the anastomotic side, or splenoportal or splenorenal stent can be done in order to decongest the left-sided portal vein. And one important problem that we also encountered is the gastric ischemia, specifically in total pancreatectomy, after total pancreatectomy or in locally advanced tumor, where you may require coronary vein resections, left gastric vein resections in order to achieve lymph node clearances. And at that time, in order to prevent gastric ischemia, coronary vein implantations are required, or subtotal gastrectomy or total gastrectomy sometimes is being added, because we faced one emergency because of the gastric ischemia, and that patients required subtotal gastrectomy because left gastric vein was accidentally not accidentally, it was being vagulated because of lymph node clearances. So what about when the tumor is involving jejunal branches? So NCCN guidelines suggest that inferior to the third part of duodenum, if it is involving jejunal branches, then it should not be, then resection should not be attempted. But many articles assume that this is the technical possibilities as there are no large data, because these jejunal branches are small caliber, there is this diameter mismatch, and there is these thin vessels, so there are very high chances of thrombosis. But yes, by technically this can be resected and anastomosis can be done. So this is ileal and jejunal, and this is mesenteric vein. Any of these two jejunal ileal branches sufficient to decongest the entire small bowel. But sometimes, if after the anastomosis, if there is any congestions in the small bowel, then this jejunal branch can also be implanted. Otherwise, generally, this is considered as contraindications, because this also shows aggressiveness of the disease. So what is the results of the venous resections? There are many single-center studies, and there are multiple multicentric studies. Single-centric studies basically shows no differences in short-term and long-term results, but most of the multicentric studies shows that morbidity and mortality are much higher in cases of the venous resections in comparison to standard Whipples resections. Then this is again Heidelberg group by Kilo Heckert and Buchler group. They published over 2,000 patients of PD data with that, then 30% of the patients they've done portal vein resections, and they found that those which required graft had increased morbidity due to portal vein thrombosis. And this data was actually prior to neoadjuvant chemotherapy. So R0 resection rate was only 10.7, but still survival advantage was 23.3 months, 3 months. But and there are many meta-analyses of now available, but all shows that these have worse short-term and long-term results of the pancreatico-duodenectomy. Only one meta-analysis shows the perioperative mortality and 1 year survival were comparable to that of so this is the one step higher surgery. So it should be done after in proper selected patients, in biologically responsive patients, after giving neoadjuvant therapy, and only those patients which are biologically and patients are surgically fit for the surgery, and should be not attempted in all patients. So what is the status of the arterial resection? So why it is prior to neoadjuvant therapy, this was contraindications for the surgery. Reason was that because mesenteric artery is covered with many perineural lymphatic plexus, so there were very high chances of R1 resections. But with this neoadjuvant chemotherapy and chemoradiation therapy, specifically with the FOLFIRINOX, now it's possible to get R0 resection even with the arterial resections. So worldwide data prior to neoadjuvant chemotherapy, it was in 337 meta-analysis, which shows 26 study and 366 cases. There were very high morbidity of 56% with mortality of 14%, and it was associated with worse survival, but it was prior to neoadjuvant chemotherapy. But after neoadjuvant chemotherapy, this is the T data from the Mayo Clinic data. It is from 1990 to 2017. Overall, it was median survival was after giving neoadjuvant chemotherapy was significantly increased. That is 29 months, which is much better than simple neoadjuvant simple chemotherapy, which is survival is 11 months. So they have also showed that before 2010, with experience, that was the mortality rate was 29%, dropped to 9% with more experience, and more experiences also increases the number of arterial resections. These resections, so in modern neoadjuvant chemotherapy time where there is possibility of the R0 resections, so more and more arterial resections are being done. So it is now not a contraindications for the surgery. So, so only way to know whether artery is involved is CT scan. This shows circumferential involvement of the artery is more than 180 degree or not. So, two, there is landmark paper which shows that actually histopathologically, those which radiologically which are showing artery involvement, actually 15% are truly invaded by artery in comparison to venous, where is 76%. And out of 15%, 91% are mainly concentrated in tunica adventitia, not going beyond tunica adventitia. So this two paper lead to concept of arterial sparing resections, which is called divestment surgery. So I will discuss divestment. This is the arterial layer. This is external elastic lamina, which is the toughest layer of the artery, and this is the adventitia. So there are different type of divestment. Divestments, one is periarterial divestments, means it is outside adventitia, periarterial tissues are being removed. Then the adventitial, then it is called periadventitial divestment, where in the adventitia, then these neural tissues are taken off, which is I already described. It is LV3 dissections, and beyond that, when the entire adventitia is being called subadventitial divestment, we directly come into the external elastic lamina by sharp dissections by cautery or harmonic. Then we bluntly remove this circumference throughout the SMA. Generally, 180 degree is preferred because beyond 180 degree, it's cause intractable diarrhea and it causes very much morbidity to the patients. So these are the forms of the divestment, which is periarterial, periadventitial, subadventitial, and this periarterial divestment is only called as level 3 dissections. So there is a Nanjing criteria pathologically based on this thing. This is the tumor, and this one is the tumor, and is not involving the adventitia. So R0 resection is possible without any divestment, and this tumor is coming into the adventitial layer, but this is the external elastic lamina, and the tumor is more than 1 millimeter away from this external elastic lamina. So in this case, sub-adventitial divestment is possible. Arterial cavity is spared with good result. But when tumor is coming very close to external elastic lamina, where distance is less than 1 millimeter, so here arterial resection is indicated because sub-divestment is not indicated in order to get the negative result. And if it is involving the external elastic lamina also, or involving the soft tissue, then the any form of resection is contraindicated. So most important thing is how you predict which patients have divestment and which patients can undergo arterial dissections. So one data of radiological data by the Habib, which shows that this is the superior mesenteric artery. If there is halo sign and without any contour deformity, then most probably it is not infiltrating external elastic lamina, which is the toughest layer. And in this cases, superior mesenteric divestment can be done with ease. But when it is involving external elastic lamina, then there is a lumen discrepancy of the superior mesenteric artery, and it is called a string sign, which is called which round shape of artery become distorted. And in this cases, the divestment is not possible, and only artery resection is possible. So this data need to be validated in most cases. This is our data, our picture, which are completely divested superior mesenteric artery. And this is, in general, is not required because it causes a high intractable diarrhea. But in this case, there's a requirement of that. This is the methods of the superior mesenteric artery dissections and reconstructions. So this is again data from the Whipples group from 2003 to 2019. This is the arterial resection data which was done prior to neoadjuvant chemoradiotherapy. And after neoadjuvant chemoradiotherapy, the target is to do mainly divestment, which is possible only after that. And in that cases, the median survival overall was 20.1 month, and R0 resection was 28%. They have shown that divestment mortality rate is 2.3%, where in arterial resection it was 7%, still high. But in arterial resection, there was high rate of post-operative pancreatic fistula, the high rate of hemorrhage, ischemia, and real So now they also prefer, if possible, after giving neoadjuvant chemotherapy, divestment is treatment of choice. But one should be very have knowledge how to do artery dissection. Sometimes divestment may result in massive bleeding, and that may require artery dissection per se. And for artery dissections, the number of minimum surgery required is 15 in order to get good results. But in divestment, this type of number of surgeries are not required. There is no learning curve, can be easily done in properly selected patients. So last few slides are with the celiac axis stenosis, which is important part in cases of pancreatico-duodenectomy, because most of these patients are advanced age. And one retrospective study by Al-Saidi et al., this is around 25% of the patient has associated celiac axis stenosis. And fortunately, only grade C, that is stenosis with more than 80%, have high chances of liver failure and post-operatic pancreatic fistula. So one should be very careful assessment. CT scan prior to that, and this is middle arcuate ligament syndrome is first, and second is atherosclerosis, more common cause. So in CT scan, if it is showing it is prominent GDA or collaterals in mesopancreas, then this are suggestive of celiac axis stenosis, so be carefully evaluated. And if intraoperative is in doubt, then intraoperative clamping of gastroduodenal artery before ligation is the standard procedure in order to see whether hepatic artery as well as mesenteric pulsation is there or not. If it's not palpable, then or evidence of liver or gastric ischemia, a management study should be planned accordingly. Then if it is diagnosed preoperatively, then maybe endovascular dilatation, possible stenting should be done. But if there is a marked atherosclerosis, then sometimes required surgery by the bypass gravity. So summarizing my the lecture, this is the so conventional radiology diagnose these stages only prior to NCT and neoadjuvant chemotherapy, and this borderline resectable locally advanced tumors are only applicable prior to NCT, and these things are not present after giving NCT because CT scan cannot differentiate between the fibrosis and tumor. T4 is not predictor of the survival, just so anatomical proximity, not biological aggressiveness of the disease. So with improvement of the systemic control of the PDAC, anatomic contraindication of surgery may be revised, and vein resection is now standard of care. And arterial involvement doesn't mean necessary arterial resection. Divestment is possible in majority of cases after giving neoadjuvant chemotherapy. Thank you very much.
Phani, maybe you can make some comments for 2-3 minutes, and then we hand over to Kailash.
I mean, it's firstly an excellent presentation, Utpal. I'd like to congratulate you. In this half an hour, you managed to cover venous resections, arterial divestment, explain to us a very beautifully explained concept of LV1, LV2, LV3 with videos. I mean, nothing much for me to add. So I think this is one video which everyone should probably, once you post it, they should go home and go through it once again. It's so much of information. Really well done. I can say that. I mean, only one point from me regarding the divestments. Subadventitial divestment, it looks good, as in the diagram and when you look at the images, but in the elderly males with atherosclerosis, the planes are not as beautiful as seen schematically. There's a lot of inflammation, and majority of the times, if in the elderly, when we have tried a couple of subadventitial diversions, you actually where the vessels branch off, you will injure the artery and most of the time end up with the dissection and bleeding, and you should be prepared to actually resect the artery. Sometimes I wonder, is it worth doing a subadventitial divestment or directly just planning a resection? Probably that will be a safer strategy.
Yes, I completely agree with you, sir.
Okay, Dwarka Clinic, can we share Dr. Kailash Kurdia's?
Sir, can try once more?
Okay. Yes,
just one, sir.
Yes.
Okay, sir. Sorry, I think same problem, so I can continue from here, sir.
Who is there? Pinesh, you are there?
जी सर.
Please, Dr. Kailash का share कर दें presentation.
जी.
Yeah, go to the first slide, please. Yes. कैलाश आप नेक्स्ट बोलते रहना, ये लोग चेंज कर देंगे.
ठीक है सर, सॉरी फॉर टेक्निकल प्रॉब्लम and late joining. So I am presenting here borderline resectable pancreatic cancer and neoadjuvant chemotherapy. But my presentation is a generic. It not only stick to the neoadjuvant chemotherapy, it may also include neoadjuvant chemoradiotherapy and some anatomical and staging part. So can you move on the next slide, please? Hello. Kindly move the next slide.
Yes, sir. One.
So, according to location, the head tumor is located to the to the right side of the left ward of the superior mesenteric vein, and the body tumor in between the this superior mesenteric vein and the right to the aorta, and left tail tumor is located to the left of the aorta. And so next slide. The staging is includes T1 tumor is less than 2 centimeter, and T2 tumor is between 2 to 4 centimeter. T4 tumor is more than T3 tumor is more than 4 centimeter, but it is not involved in the arterial vasculature, and if it is involved arterial vascular, then it is the T4 tumor. Next. So since NCCN first described the borderline resectable pancreatic cancer, the definition mainly based on the anatomic criteria, and more specifically on the extent of venous and arterial involvement by the tumor. So anatomical definition of BRPC is a tumor that is high risk for margin positive resection when surgery is used as initial treatment strategy. And margin resection is important in ensuring the best prognosis. Next. So there are multiple definition of borderline pancreatic cancer is available, but kindly next move to next. There is an international consensus given for the borderline pancreatic cancer, which is kindly move next. So borderline subclassified according to SMA portal involvement alone or arterial invasion. So SMA portal vein involvement alone is the if tumor is tumor contact 180 or greater, or bilateral narrowing or occlusion of the SMA portal vein, which is not exceeding the inferior border of the duodenum. And also there is no tumor contact or invasion to SMA, celiac axis or common hepatic artery. Or in case of arterial involvement, SMA celiac axis tumor contact of less than 180 without showing deformity or stenosis. Or CHA, in case of CHA, tumor contact without showing tumor contact of the proper hepatic artery and or celiac axis. Next. So this is the diagram is Dr. Utpal already said how to assess the jejunal vein. So it is very difficult to assess the jejunal on radiography. So by to see the relation of the tumor to the duodenal, it can easy to the whether it is the involvement of jejunal vein is there or not, because it is one of the important factors by which you can decide whether you are able to reconstruction or not. Okay, next. So again, depending on the which type of portal vein involvement, it also associated with prognosis. As in we saw in if a type A just there is abatement, then the prognosis is better than the type B, which is just unilateral involvement, and in type C there is bilateral narrowing of the portal vein SMA, and in case of type D, if it complete occlusion which is displayed by the collateral, then the prognosis is further worsening. Next. Kindly next, skip because of the shortage of time. Okay. Next slide. So this is the This next slide. Go on next slide. Again, go on next slide. So now coming, what are the various prognostic factors associated with the pancreatic tumor? So despite recent advance in multidisciplinary treatment approach, still relapse rate are as high as 70% within 2 years. And the risk of tumor recurrence depend on various factors. One is the unique and aggressive biology of pancreatic cancer, and various pathological characteristics such as lymphovascular and perineural invasion, nodal metastasis, positive resection margin. So after implementation of standardized protocol for pathologic workup, which rapidly increased the number of reported R1 rate from 20% to 80%. Next. So as after the standard protocol, and if the tumor is located in the uncinate, especially in the uncinate part, and if you see the arterial vasculature is located here, so there is on proper slicing of the specimen, exact resection margin can be told whether it is R0, R1 or R2 resection. Next. So there are survival data following for curvature and non-curvature surgical resection curative and non-curative surgical resection for pancreatic cancer. As we saw, if there is a R1 resection is there is a median survival was significantly lower than the if the patient achieve the R0 resection, which ranging from 12 months to more than 55 months, but in R1 or R2 resection, it ranging between 6 to 22 months. Next. So, coming to the BRPC and neoadjuvant chemotherapy or neoadjuvant treatment. So, over last decade, several studies on this topic have been published. However, debate about the best management for pancreatic borderline resectable pancreatic ductal adenocarcinoma still remain open. Since the available literature does not provide high-level evidence, most of the studies that advocate neoadjuvant treatment are because of non-randomized trial with selection bias by reporting survival after resection rather than by intention to treat analysis. Moreover, due to extreme heterogeneity of the definition of borderline resectable pancreatic cancer adopted by published studies, the interpretation and comparison of the result are very difficult. Next. So, what are the advantages of neoadjuvant treatment? It leads to early systematic treatment for undetected micrometastasis, as well as increase of R0 resection rate and reduction in term of post-operative pancreatic fistula. But it also associated with some disadvantage like reduction of chance of surgery due to disease progression during the treatment, and also the literature show limited significant down staging. But currently, the NCCN guideline recommend the neoadjuvant treatment of borderline resectable pancreatic cancer rather than upfront surgery. Next. So this is the one of the first randomized trial which published in 2018 to assess the benefit of neoadjuvant chemoradiation with gemcitabine versus upfront surgery in patients with borderline resectable pancreatic cancer. So this was a phase 2/3 trial. In this total 110 patients designed to enroll with borderline pancreatic cancer, and the gemcitabine based chemotherapy neoadjuvant chemoradiation treatment with 54 gray EBRT followed by surgery, or upfront surgery followed by chemoradiation treatment for large volume center was done in Korea. And the primary endpoint was 2-year survival rate, and the interim analysis was planned at the time of 50% case enrolled. So in both groups, the tumor characteristics are comparable, including tumor size of 3.4 and 3.5, as well as clinical T stage, N stage. Always, though there is a difference, but no clinical significant difference in the clinical end stage, as well as location of the tumor and vessels involvement. Next. The results showing after excluding the patient who withdrew consent, total 58 patients enrolled and 27 patients were allocated to neoadjuvant treatment and 23 to upfront surgery group. The overall 2-year survival was 34% with a median survival of 16 months, and intention to treat analysis showing a 2-year survival and median survival in a neoadjuvant treatment group is 40.7% and median survival is 21 months. In comparison to the upfront surgery group, we saw the 2-year survival is 26.1% and median survival was 12 months. And also the higher R0 resection rate in the neoadjuvant treatment group, which is 51%, and in upfront surgery group around 26.1%. And also pathological finding and tumor response of patient undergoing surgery in the showing that there is significant decrease in the tumor size also present, as well as patient having around 10% of the patient having complete response in the neoadjuvant treatment group. And there is a significant increase in the R0 resection rate. Rest of the parameter is comparable. Next. So again, this curve is also showing according to intention to treat analysis, there is significant survival advantage seen in the case of neoadjuvant treatment group than the upfront surgery group. However, the per protocol analysis showing there is no difference in the survival group. So looking to the recurrence pattern after neoadjuvant treatment and upfront surgery, there is no significant difference in the both groups. So overall recurrence in the neoadjuvant treatment group is around seen in 88% and also in the similar to the upfront surgery. And interestingly, the loco-regional recurrence rate, even the higher rate of R1 resection, it is also comparable in the both group, neoadjuvant as well as the upfront surgery group. Next. So this is another randomized trial of in which they compare the chemoradiotherapy versus immediate surgery for resectable and borderline resectable pancreatic growth. In this patient, they also include the both resectable as well as borderline group. This was a in the neoadjuvant adjuvant treatment. They include the preoperative CT-RT arm, which include the 3 course of gemcitabine, and second cycle combined with 15.2 gray of 15 cycle of 2 gray each radiotherapy and followed by surgery, and followed by 4 course of adjuvant gemcitabine in the neoadjuvant group, while in the immediate surgery group, patient underwent upfront surgery, and which was followed by 6 course of adjuvant gemcitabine chemotherapy. And primary endpoint was overall survival by intention to treat analysis. Total 240 patients randomly assigned, in 190 in the neoadjuvant and 127 in the immediate surgery group. The median overall survival was 16 months versus 14 months, which is not there is no significant difference. However, the resection rate was also there is no significant difference. Sorry, the R0 resection was significantly higher in the neoadjuvant treatment group. So neoadjuvant treatment was associated with significantly better disease-free survival and local regional failure-free survival. Also showing a significantly lower rate of pathological lymph node, perineural and venous invasion. And survival analysis of patients who received adjuvant chemotherapy saw improved survival in neoadjuvant treatment group, which is 35.2 versus 19.81. It means those patients after neoadjuvant chemotherapy underwent surgery and then again received the adjuvant treatment, they have significantly higher survival rate. Next, please. So this is the table which is showing the baseline patient and tumor characteristics by treatment regimen. In this table, we saw that borderline resectable pancreatic cancer was in preoperative CTRT around 45%, and in immediate surgery was it was around 47%. And the mean CA99 level was higher in the immediate surgery group, but which was not a significant, statistically significant. And these curve are showing there is a period operative chemo radiotherapy in comparison to immediate. There is no significant difference in oral survival. However, there is the patients on disease-free survival, local regional failure free survival, as well as distant metastasis free survival. So these disease-free survival and local regional failure-free survival is significantly higher in those patients underwent preoperative chemoradiotherapy. But there is no difference in the distant metastasis free interval. Next. So again, intention to treat analyze a primary and secondary endpoint for both subgroup of patients with resectable and borderline solving. In this patient, the in case of borderline resectable pancreatic cancer, which include 113 patients, the resection rate was though low in the preoperative chemoradiotherapy group, but R0 resection is significantly higher. And again, the survival curve is showing in case of borderline resectable, it is preoperative chemoradiotherapy group have significantly better overall survival, as well as disease-free survival and local regional failure-free survival. Next. This is one more randomized control. This is the long-term outcome of this same trial, which at the median follow-up 59 months. So overall survival was better in Neoadjuvant group than the upfront surgery group, although the difference in the median survival was only 1.4 months. The 5-year overall survival rate was 20.5% in the Neoadjuvant treatment group, then compared to the 6.5% in with upfront surgery group patient. Next. Next, please. So this is the recently published another trial, randomized control trial of aspect 5, which include the divide the patient in forearm immediate surgery, then short course Neoadjuvant gemcitabine plus capecitabine, another regimen is folfirinox, and fourth arm is the chemoradiotherapy in patient with borderline resectable pancreatic cancer. So it was a multi-centric open-label randomized control trial done in the UK and Germany. Next. The treatment group, as I already mentioned, there are 4 groups. So next, kindly continue next. So post-Neoadjuvant treatment, patient underwent restaging CT scan after 4 to 6 weeks of Neoadjuvant treatment and underwent surgical exploration if the tumor was still at least borderline resectable. All patients who had their tumor resected received adjuvant therapy at the oncologist discussion, and primary endpoint was recruitment rate and resection rate. Analysis were done on intention to treat basis. Next, please. So total 478 patient was screened, and finally 90 patient was randomized. Rest of the patient excluded for various reasons, and 33 patient allocated to emergency surgery, 20 allocated to Neoadjuvant gemcitabine and capecitabine, and 20 patient to folfirinox, and rest of the 17 patient allocated to chemoradiotherapy group. Next. The result was showing the recruitment slow, but 40 patient out of 55, which is around 80%, completed Neoadjuvant therapy, and 6 of these patients had partial response, and 21 of 31 patients in immediate surgery, and 30 of 55 in the combined Neoadjuvant therapy group underwent resection. Next. The outcome show immediate surgery group versus neoadjuvant therapy group. The R0 resection was in 14% patient versus in 23% of patient in the combined, including all modality of the neoadjuvant treatment. And median follow-up time was 12.2 months. On that, the 1 year overall survival was 39% in the upfront surgery group versus 78% in the for gemcitabine plus capivasertib group, and 84% for FOLFIRINOX group. And how in case in chemoradiotherapy group, it was only 60%. Again, the 1 year disease-free survival was lower in the upfront surgery group, which is only 33% in comparison to 59% for combined neoadjuvant therapy. 3 patients reported local disease recurrence, 2 in the immediate surgery group and 1 in FOLFIRINOX group. So in conclusion, short course neoadjuvant treatment had significant survival benefit compared to immediate surgery group. And neoadjuvant chemotherapy with either gemcitabine plus capecitabine or FOLFIRINOX had the better survival compared with immediate surgery group. Next. Now there is multiple meta-analysis which comparing upfront surgery with neoadjuvant treatment in patient with resectable or borderline pancreatic cancer. This is the one of the first meta in which the total 38 studies are included of 3,484 patients, of whom 1,738 patients had neoadjuvant treatment group, around 50%. The median overall survival by intention to treat was 18.8 months for neoadjuvant treatment and 14.8 months for the upfront surgery. The difference was larger among patients whose tumor was resected, which is 26.1% versus 15.0. Sorry, 26.1 versus 15.01 ratio. The overall resection rate was lower with the neoadjuvant treatment than with upfront surgery, but the R0 resection was higher in the neoadjuvant treatment group than the upfront surgery group, which is around in neoadjuvant treatment group 86% and in the upfront surgery around 67%. So reported by intention to treat, the R0 resection rate were 58% and 54% respectively. And the pathological lymph node rate was 43% after neoadjuvant therapy and 64.8% in the upfront surgery group. So neoadjuvant treatment appeared to improve overall survival by intention to treat despite lower overall resection rate for resectable or borderline resectable pancreatic cancer. Next. This is another systematic review and meta-analysis. We saw oncological benefit of neoadjuvant treatment versus upfront surgery in borderline resectable pancreatic cancer. This is especially in borderline pancreatic cancer. In this, they compared the survival between BRPC patients who underwent neoadjuvant treatment and those who underwent upfront surgery. The overall survival was compared using intention to treat analysis. Total 1,204 publications were identified and 19 publications with 21 data set, including 2,906 patients in the neoadjuvant treatment group and 1,560 patients in upfront surgery were analyzed. 2 randomized control trial and 2 prospective studies were included in this meta-analysis. 13 studies performed an intention to treat analysis, while 6 presented the data of resected patients. The neoadjuvant treatment group had significantly better overall survival than upfront surgery group in the intention to treat analysis and resected patient. So among the resected patient, the R0 resection and node negativity rate were significantly higher in the neoadjuvant treatment group. And neoadjuvant treatment improved the overall survival, R0 resection rate and node negativity rate compared with upfront surgery group. Next, please. This is another meta-analysis which showing the neoadjuvant therapy for or upfront surgery for resectable and borderline resectable pancreatic cancer. There are 7 trials with 938 patients were included. All trials included a Neoadjuvant gemcitabine-based chemo or chemoradiotherapy arm. None of the studies used adjuvant FOLFIRINOX. Neoadjuvant therapy improved oral survival and compared with the upfront surgery. And this represents an increase in the median oral survival from 19 to 29 months. And in subgroup of resectable pancreatic cancer, no statistical significant difference in oral survival was observed. In the subgroup of borderline resectable pancreatic cancer, neoadjuvant therapy improved oral survival. So with this, they concluded neoadjuvant therapy improved oral survival compared with upfront surgery in patient with borderline resectable pancreatic cancer. Next, please. So there are these are the multiple study in which the borderline resectable these two study having included the isolated borderline pancreatic resectable group. So kindly next please. So outcome with neoadjuvant therapy or upfront surgery. So the oral results is showing the resection rate is lower in the neoadjuvant treatment. However, the R0 resection rate is significantly higher, as well as pathological N0 stage is significantly higher in the neoadjuvant treatment group. And there is no significant difference in the major complication group. And the grade of summary of these finding for median oral survival in neoadjuvant therapy, it was 29 months. Then in compared to the 19 months for upfront surgery, which is the grade of evidence is high. For resection, it is around 80 to 100% in the upfront surgery group. And neoadjuvant, again, that is 75 to 100%. And the grade of evidence is moderate. For again N0 resection or major surgical complication, the so for N0 resection it is moderate, and for major surgical complication the grade of evidence is low. Next. So again, outcome of primary chemotherapy for borderline resectable and locally advanced pancreatic ductal carcinoma. So this was the objective of this study was to investigate fragmentally the treatment compliance, conversion to surgery, survival outcome of patient with borderline resectable and locally advanced pancreatic cancer. And this prospective study took place in National Referral Center for Pancreatic Disease in Italy. Conjugate to patient with borderline resectable and locally advanced pancreatic ductal carcinoma enrolled at the time of diagnosis. Next, please. The result showing around 60% of the patient have borderline resectable pancreatic cancer, and around 10% of the patient lost to follow-up, and 92% of the patient receive chemotherapy. The chemotherapy regimen most used FOLFIRINOX and gemcitabine plus nab-paclitaxel. In this session, 19 patients receiving chemotherapy died within 6 months, mainly for disease progression, and the treatment completion rate was around 70%. Next, please. The oral resection for oral rate of resection was around 15.1%, and in borderline resectable case, it is around 24%. In case of locally advanced, it was only 9%. The independent predictor of resection were include the age, borderline resectable disease, chemotherapy completion, radiological response, and biochemical response. The median survival for whole cohort was 12.8 months. Factor independently associated survival were again completion of chemotherapy, receipt of complementary radiotherapy, and resection. In patient who underwent resection, the median survival was 35.4 months for initially borderline resectable patient, and 41.8 months for initially locally advanced patient. Next. So this is the recent meta-analysis published recently, which comparing the upfront surgery and neoadjuvant therapy in the both resectable and borderline resectable pancreatic cancer. So study comparing neoadjuvant therapy with the upfront surgery in resectable and borderline resectable pancreatic cancer. Primary endpoint was overall survival. Total 10,000 studies were identified, and the meta-analysis finally enrolled 50 revealed studies. And the meta-analysis suggests that neoadjuvant therapy significantly improved the overall survival as well as recurrence-free survival. Next, please. Next.
I think you will have to summarize.
Yes, sir. No, just two more slides. Furthermore, neoadjuvant therapy lead to favorable post-operative outcome with an enhanced R0 resection rate, reduced lymph node metastasis, and perineural invasion, although it is associated with reduced resection rate. In addition, patients treated with the neoadjuvant therapy experience superior survival benefit compared to those undergoing adjuvant therapy. And neoadjuvant therapy has the potential to provide survival benefit and improve post-operative long-term outcome for patients with resectable and borderline resectable pancreatic cancer. However, to validate and reinforce these findings, further well-designed and large trials are required. Next. Next. So, in conclusion, around 30% of the patients present either borderline resectable or locally advanced. And due to architectural feature of borderline resectable pancreatic cancer, as these are located near to the vessels, especially the tumor is located in the uncinate, upfront surgery result in higher R1 resection rate. So neoadjuvant treatment could degrade the stage and improve the R0 resection rate. In addition to controlling local disease, it also assesses the biology of tumor. So in summary, neoadjuvant treatment is primarily used to select suitable surgery candidate and improve the tolerance of preoperative treatment. The superiority of neoadjuvant chemotherapy and neoadjuvant chemoradiotherapy for borderline pancreatic cancer remain unclear, and there is still controversy about the most appropriate neoadjuvant treatment regimen. However, the NCCN guideline recommend FOLFIRINOX or modified FOLFIRINOX plus minus radiation, or gemcitabine or capecitabine should be the used as a neoadjuvant in treatment for in case of borderline resectable cancer as a first line regimen with or without radiation therapy. Thank you.
Phani, we are already at 9, but maybe quick 2 or 3 minutes comments on Kailash's presentation.
Yes, Kailash, I think, yeah, a very thorough presentation. One thing you clearly established is that definitely borderline resectable pancreatic tumors, neoadjuvant it's now a dictum. But in terms of neoadjuvant chemotherapy versus radiotherapy, I mean, is it, am I to understand that there's only one study in that area, the SPAC-5, and in that, I didn't understand the conclusions. Did they conclude that the FOLFIRINOX and paclitaxel, that group only, the gemcitabine, those groups only provided survival advantage? Because in the conclusion, you didn't mention that there was no survival advantage of the radiotherapy group. And that's one question. And the other thing I wanted to ask you is, am I to understand that after neoadjuvant chemoradiotherapy, the only non-progression is the only criteria which you said to how do you select patients for surgery? Or is there any other things which have been reported in literature, like how much percentage the CA99 should come down or anything like that?
So actually, regarding first question, in ASPECT trial, the maximum benefit was seen in those patients who received the FOLFIRINOX or gemcitabine nab-paclitaxel. Though in the chemoradiotherapy group, there is increased survival in comparison to upfront surgery, but it is less than the group of modified FOLFIRINOX as well as gemcitabine or nab-paclitaxel.
So as of now, it's either equal or possibly superior. Is that the conclusion? Chemotherapy to radiotherapy. As of now, there's no non-inferiority. It's not inferior to radiotherapy. Is that what you can say?
Yes, sir. This is no. There is no conclusive whether it is radiotherapy or neoadjuvant. Only chemotherapy. There is no conclusive evidence to which is the better, whether it is superior or which is inferred. There is no such conclusion can be made by available literature.
There's
And,
there is very
yes.
little evidence to compare chemotherapy versus chemoradiotherapy.
Yes.
But most of the centers do not favor radiotherapy due to some technical issues for arterial reconstructions or venous reconstructions. Most of the high volume centers, either the Del Chero group or Heckert group or the Buchler group, all are not giving radiotherapy. They are basically preferred neoadjuvant chemotherapy specifically for the patient where they are planning for arterial or venous resection.
That is the reason
In
there is
India also, it's almost all
evidence
groups.
compare.
So what was your second question, sir?
No, second question was like, in one of the last trials, you said only 15% became resectable after borderline resectable. So is non-progression the only criteria to take them up for surgery? If there's non-progression, take them up for surgery, or they use the other criteria that CA910 should be come down by 50%, or any such.
That is the only anatomical criteria, whether it is stable disease or maybe partial response or complete response, but that is the criteria.
I mean, I think basically what I've instance, I think after neoadjuvant chemotherapy, you really don't need, you can't assess if it's a partial response or a complete response. The response is difficult to assess on imaging. And the
Yes.
only criteria is there's non-progression, you're happy enough to go ahead and take them up for surgery.
Yes, sir.
Thank you.
So, though there is a biological criteria is seems to be more practical, but till date, most of the literature is follow only the anatomical criteria for assessment of the response assessment as well as the resectability.
Thank you.
I think we are already at 9:05, so we will have to close. I would like to thank all the three speakers and Phani for moderating, and Dr. T.D. Yadav and Ashwini and Harjeet for attending. And thanks to Dwarika Clinic team for technical support. See you in the last week of August for the next masterclass. Thank you, everyone.
Thank you, sir.
Thank you. Thank you.
Thank you.